presentation. It's given by Alice Street. She's a senior lecturer in social anthropology at the University of Edinburgh. Alice Street research includes studies of health system, global health intervention, and medical innovation. And she will speak about the social life of COVID-19 testing. Professor Street, please.
Thank you very much. Well, first, I would like to thank all the organisers for inviting me to be part of this fantastic pan-European UNICA webinar. It's wonderful to be meeting so many other researchers from across the continent to discuss such an important issue. Let me now share my screen so you can see my slides. So today I will be presenting the research of myself and my team that we've been carrying out at the University of Edinburgh around the social life of diagnostics in global health. And this has included research in Papua New Guinea, in Sierra Leone, and in India and in the USA. And since spring, we have reoriented this research to examine social aspects of COVID-19 testing, and we've received funding from the Scottish Chief Scientist's Office to conduct research on how public expectations, experiences, and perceptions of COVID-19 testing in Scotland influence people's trust in the government's response to the pandemic. As COVID-19 has spread across the world, testing has taken centre stage of global efforts to halt its progress. Now, diagnostics have traditionally been a very neglected aspect of medicine and public health, receiving far less funding, for example, than drugs or vaccines. But COVID-19 has really highlighted the fundamental importance in delivering effective testing regimes during a public health emergency. Testing, we all know now, is absolutely crucial in an outbreak scenario. From a medical perspective, it enables triaging to support clinical decision-making. Even more important from a public health perspective is that it enables us to determine who should quarantine to cut chains of transmission. But in the context of COVID-19, the value of medical testing is expanding. So for governments, for example, testing is not only a tool of public health, but it's also a key means of reopening the economy. And for members of the public, tests might provide some kind of medical reassurance, but they also hold immense value for enabling people to resume relationships of intimacy that would otherwise be put on hold. At an individual level, testing can enable people to travel to see loved ones, and at a population level, knowing that a testing regime is in place can give people the confidence to meet with close friends and relatives. So these high expectations of medical testing are premised on the idea that biomedical tests can deliver some kind of diagnostic certainty. They can give us some kind of clear knowledge of what someone has and what's going on biologically. But in fact, our research has found that diagnostic tests are uniquely fragile medical technologies, and that diagnostic certainty is inherently unstable. Even when a test has been shown to be highly accurate in laboratory studies, its accuracy and reliability remain susceptible to the wider context in which it is operationalized, including the reliability of data entry systems, the training of patients or health workers to take a sample, or the proper storage of chemical reagents used to activate them. Tests are therefore only as reliable as the systems and the relationships that surround them. And this inherent uncertainty that accompanies medical testing means that a test's efficacy, in the sense of its ability to facilitate a clinical or public health decision or change a behaviour or enable government to make effective decision-making about how to exit lockdown, all of this depends fundamentally on trust. And trust is a kind of social relationship. And this is where I think social scientists can really have some input and offer their expertise for understanding how people engage with testing programs and how the power of testing can be most effectively harnessed for the pandemic response. In other words, how to build trust in testing. So testing, we have found, includes multiple relationships, and each of these relationships hinges on trust. So it includes trust in the test itself, which is linked to expectations that a test should be accurate and that it should be manufactured to a high quality. It involves trust in a health system, trust that the health system has qualified health workers, that it has qualified laboratory personnel, that it's organisationally competent, and that it is able to provide care. It involves trust in government to put in place the policies and the resources needed to make accurate tests available and to care for their citizens enough to provide these tests. And it involves trust in others to undergo testing to protect those around them and to adhere to quarantine guidelines. So in the remainder of this presentation, I would like to speak across three contexts in which we have explored the fragility of these relationships of trust in testing regimes to draw out some of the implications for how we might manage COVID-19 testing. So in Sierra Leone, we looked at the role of diagnostics in the Ebola West Africa outbreak in 2014 to 16 and its aftermath. And what was really notable was that just as with COVID-19, there was an immediate recognition of the importance of testing to containing the outbreak. However, the investment in testing regimes was very much focused specifically on Ebola testing technologies and testing capacity, and not in the wider diagnostic infrastructure, even though it was because of the weak laboratory infrastructure more broadly and the weakness of transportation systems and the very few numbers of biosafety facilities and the few numbers of laboratory technicians who had the skills to do PCR testing that had led to the problem of a lack of capacity of Ebola testing. So the focus was very much on Ebola diagnostics. And this meant that after the outbreak ended, there was still very limited laboratory capacity in many of the clinical settings in Sierra Leone. And our research in laboratories and hospitals and rural clinics in Sierra Leone showed that there was intense distrust within the health system between the clinic and the laboratory. And this meant that while laboratory tests were often ordered by clinicians, they were very rarely acted on, and patients were both diagnosed and prescribed therapy prior to test results coming back. And this was because test results took a long time to come back, but also because there was this inherent distrust in the capacity of the laboratory and the skills of the laboratory technicians. And this also meant that clinicians often actually tell patients to go and access their tests in private facilities outside the hospital or outside the health facility, even though those health facilities have labs. And this increases the burden of cost on patients, but also leads to a very fragmented kind of diagnostic system between the public and the private. And it left patients often within a sense of intense uncertainty about what they have. They often had multiple tests done, and they very rarely got a certain diagnosis. And this contributed to a kind of broader distrust of the health system and of the government to provide an effective system of care for patients. So this gives us a bit of a sense of how kind of trust in tests can actually relate to broader trust in the health system and in government, but it also indicates the importance of there being trust within a health system between different parts of it. Another relationship of trust that is very important is when we try and cultivate trust in tests. This depends very much on those tests being regulated by regulatory authorities and us having a sense that the tests that are available on the market are of a high quality. And what we saw in Ebola and what we've also seen with COVID-19 are efforts to speed up regulation as a way of incentivizing product development. These are both diseases for which there were no rapid diagnostic tests commercially available at the beginning of the outbreaks, and also to try and innovate in medical testing so that those tests themselves might be faster and might be able to be decentralized away from the laboratory. So we saw with Ebola that the WHO introduced the emergency use listing procedure in order to reduce the kind of evidentiary burden being placed on manufacturers so that they could submit new Ebola tests for listing, which they did not have necessarily large-scale clinical performance evidence for. And this emergency use listing was premised on the idea that more uncertainty around the quality of tests would be tolerated in the context of an emergency. But clearly, this is itself a kind of context of radical uncertainty, because it isn't really clear how far you should lower the kind of evidentiary requirements in relationship to those needs. And often, as we've seen from the earlier presentations today, what those needs are changes through the course of an epidemic, and are often also unclear if we haven't already done the kind of broad prevalence surveys that we had presented earlier. And so these relationships of trust in regulators depend on the public trust in regulators. So we've seen with the COVID-19 outbreak in the UK that actually there's quite weak trust in regulators in Scotland from the interviews we've done, that there is a sense that maybe a lot of the manufacturers of tests are, that the government's sort of in the pocket of kind of large private corporations. And there's a sense that maybe the regulation of these tests is actually quite low. In Sierra Leone, during Ebola, we saw that there was a concern that the WHO's regulatory systems didn't really take the very specific concerns and needs of the Sierra Leone health system into consideration, and was somehow making decisions that were quite distant from them because they didn't actually include people from the Sierra Leone health system in those regulatory decision-making processes. So that shows how important building those kinds of relationships of trust are. I'll move on. And then the third testing context that I wanted to speak about relates to people's trust in government. And this relates to the most recent research that we've been doing on COVID-19 in Scotland. And this included doing 64 tele-interviews with members of the public in the Lothian area of Scotland, which has been one of the areas most acutely affected by the outbreak, especially now the second wave, to understand people's perceptions, expectations, and experiences of testing. And what we found was that there was a real disconnect between why testing matters to government and why testing matters to people personally. So the government media communications often focus on test numbers and procurement of test kits and devices, but often ignores the multiple reasons why testing matters to people. For example, in terms of relationships of intimacy, and also ignores people's experiences of getting tested. The focus on testing numbers just treats testing like it's some kind of instantaneous event and a purely technical process. Instead, we have found that testing entails huge amounts of work, and that this work is really carried out by the people getting tested or by the guardians of the people getting tested. And this is really going unrecognised and unacknowledged at a kind of government policy level. And this work involves things like interpreting symptoms. So there is a clear criteria for when someone should decide to access a test. Only sometimes that criteria actually isn't that clear. And people have to do some work kind of interpreting their body and relating their understanding of their body and what they're experiencing physically to this sort of set criteria. So there's the work of deciding whether to get a test done. And then there's the work of accessing the test. In the UK, I'm sure many of you may have heard that we've had multiple problems with the kinds of digital interface to try and access testing. Early on, we had problems in terms of the capacity of tests. And this occurred again when schools reopened, that there weren't enough tests and people were sent to testing centres very, very far away from where they lived and often had to drive 2 or 3 hours to access a test. Our testing centres are often located outside of the city and depend on people having their own personal transport to get to them, but many people don't actually have their own cars, and we're told not to use public transport to get to them. And home tests can take 3 or 4 days, and so people have to self-isolate for that time, which obviously places a huge burden on people in terms of their employment situation and childcare situation. And then there's also the experience of undergoing testing. So what we found was that many people were very unprepared or underprepared for the experience of testing. Somehow the way it was presented by the government communications and in the media is that this is just a kind of instantaneous event and you have a swab taken. Instead, people turned up to discover they had to take their own swab and they had to take their own sample, or they had to take the sample from their children. And people found this both disconcerting in that they sometimes didn't trust themselves to have taken the sample correctly, and this also impacted on their trust then in the test results. But it also, in some cases, was quite traumatic when they had to kind of inflict pain in taking the test on their young children. And they felt they had no preparation for this experience in this event. And it both undermined trust in the test result, but also sort of trust somehow that the government was engaging with and understood their own experience of testing. And then last, of course, testing entails the work of acting on the result. And as we all know with COVID-19, this isn't so much down to, in most cases, isn't so much down to clinicians deciding on therapeutic management, but it's down to people deciding to quarantine and self-isolate. Deciding to do this obviously can be hugely impractical, difficult and upsetting. Therefore, it's incredibly important that people do have trust in the test result. And there are so many kind of gaps along that testing process that if people are going to find it very difficult to self-isolate, then it's very easy to find the sort of chinks in the certainty in order to undermine that decision to do so. One thing we found was that the majority of the participants in our study were women. So more women were signing up for this study. And they also were saying that they were signing up because they felt a responsibility to try and improve the testing regime in Scotland. But we also found that of all our participants, the women were most likely to bear the testing burden of making these decisions, whether it was interpreting symptoms, accessing tests, doing the swabs, or making a decision about whether the household was going to self-isolate. And so I think it's really important to sort of recognise the work that women are doing in bearing this testing burden within the household. I think one of the important takeaway points is that there are so many points in this testing process that trust can break down. It's not just about how good the technology is. And there's a desire for life constraints and circumstances and needs to be recognised and understood in the testing system. So what we found is that the issue is not just trust in government to provide, to be competent enough to provide an effective trusting system, but there's a real desire to see in this emergency scenario that government cares in some way and is in touch with people's lives. And this is what's really being measured and judged in people's testing experiences. So concluding remarks, testing is meant to deliver certainty, but it is actually an inherently deeply uncertain process. Testing is also a social process because it entails multiple relationships of trust. And it's important to see that social process as distributed in time and in space and is involving multiple relationships along that trajectory, both from the moment in which people are interpreting symptoms to the moment in which people are acting on results. These relationships are put under strain in an emergency, and there's a need to understand people's experience of testing as a social process in order to try and build trust and ensure that people have access to tests or are able to act on those results. So some suggestions we have are around improving the communications around the testing experience so people are better prepared for that testing experience. Embedding testing within established relationships of trust. One of the issues in the UK is that the contract for community level testing was given to large corporations who do this sort of centralised testing regime, and there was quite poor trust in those corporations, whereas there was very high levels of trust in health workers and in the national health system. So there's a question about where you embed testing regimes to ensure that relationships of trust that have already been established historically can be built on. I think it's important that we focus on the testing process rather than just the testing technology, and that we engage with people's circumstances and constraints to make it possible for them to act on results. And this includes also managing uncertainty and ambiguity at multiple points along the testing chain rather than ignoring it. For example, around the criteria for symptoms and criteria for accessing a test, which appear to be very clear and say you should access a test if you have either a fever, a cough, or loss of taste and smell. But of course, for many parents with small children, they feel like they get fevers all the time. And so there's this constant sort of sense that they actually have to interpret whether this is really a fever linked to COVID-19 or not. And when it's so difficult sometimes to access a test, that kind of provides this kind of space for maneuver in whether they decide that they actually meet the criteria or not. So I think it's important that we engage with that uncertainty and ambiguity rather than ignore it completely and place that burden of making those decisions on individuals. Thank you.
Thank you very much, Professor Street. It's an excellent and important lecture.